All right. So just before we get started, I just wanted to take a few moments to orient any of our new attendees to the Project Echo platform. This platform aims to support case-based virtual learning that connects experts to public health officials, responders, and clinicians working in the field. The Echo model is built on the principle of all teach, all learn, where communities can learn and share together to promote best practices, share experiences, and access experts in the field. Next slide. This learning series was awarded to Denver Health by the Robert Wood Johnson Foundation via the Echo Institute, and will continue holding sessions twice a month through September 2026 on topics critical to disaster preparedness. We hope to reach our Region 8 audience in Colorado, Utah, Montana, North Dakota, South Dakota, and Wyoming to strengthen preparedness and response through shared learning. We encourage open discussion, whether it's questions, comments, or relevant professional experiences in these sessions, so please feel free to raise your hands, come off mute, or put any questions or anecdotes in the chat. And next slide. And then lastly, we just have a couple brief disclosures before we begin. This grant is funded through the Administration for Strategic Preparedness and Response, and the content is produced by the individual presenters and does not represent the official policy of the U.S. government. Additionally, this information is not meant to be a substitute for professional medical advice, diagnosis, or treatment. And then lastly, at the bottom there, we have a not so brief disclosure for those claiming CE credits associated with today's session. I'll share a survey link at the end of the session in the chat that you can use to claim credits. And I think with that said, we are all good to kick it off. So I'll go ahead and introduce today's presenter, Dani Berggraf. She has a background in nursing and currently serves as the Assistant Readiness and Response Coordinator for the Northwest Regional Healthcare Coalition here in Colorado. She responded to the 2014 Ebola outbreak in West Africa working as a nurse, and is here today to share her experience as it informs healthcare response in rural settings. All right, thanks, Dani.
All right, thank you for having me. I'm really excited to be here. It's been a minute since I've been able to talk about my Ebola experience. I was there for just under 2 years, so from 2014 to 2016, and was in Sierra Leone, but was able to travel to a couple of sites across that country. But just a little more about me. My background is emergency and trauma nursing, and I have been on the hospital administration side for the last, little under a decade. And more recently, I've moved over to more of an emergency preparedness role for the region, working with the Healthcare Coalition, like Katie explained. So here's a little bit about what our objectives are today. We've got to keep it professional. So I'm just going to describe my experience in West Africa. Just a little bit of information about how to recognize Ebola, especially the differences between the two strains going on right now. Talk about practical strategies to strengthen preparedness and partnerships, both regionally and locally, and then just kind of apply some of my lessons learned, which honestly are quite simple, from my time in West Africa and Sierra Leone, which is a beautiful country, beautiful people. And I think my experience was a little bit unique in that we partnered with the government of Sierra Leone. And so I was working alongside the local healthcare workers. And so I have so many beautiful relationships from that experience that I'm excited to talk about today. So, all right, so here's our current situation. As you all probably know, the current outbreak is in the Democratic Republic of the Congo, and then has spilled over across the border into Uganda. This slide was created a couple weeks ago, so don't perfectly quote me on my statistics here, but there's quite a large number of confirmed cases, so about 1,200, and we expect that actually to be higher, just as reporting and all of that gets underway. There's been a significant amount of death. And then in terms of how we are looking at from the United States as a region, we would categorize our risk level currently as low, but of course preparedness remains high. And so we're just going to talk about what that looks like today. Here's a little bit of information regarding the differences between the two outbreaks. I think the biggest call out here is it's two different strains of Ebola that we are working with. So in 2014, I was dealing with the Zaire Ebola virus, and it was in Guinea, Liberia, Sierra Leone. there were almost 30,000 confirmed probable and suspected cases, again, probably more. And then the deaths were around that 11,000 mark. At that time, we didn't have really any vaccines or approved treatments. And then the CDC and other international emergency response organizations, it was kind of the first time we kind of globally work together, especially in the United States. I'll talk about the checkpoints and a little bit more and how that applies today. But it was a really big global and international response. And then today, I hope I'm saying this right, but we're dealing with the Bundibugyo outbreak. And so, like I said, 1,200 confirmed plus cases, and there are no vaccines approved at this time. There is a vaccine for the Zaire strain that we actually worked on in 2014. I was a part of some of the clinical trials to administer it, but unfortunately, it doesn't cross over to the strain. And I think as we've learned with things like COVID, vaccines really are the game changer in outbreaks and what slows things down. So we're really hoping, or I'm really hoping, that is getting rapidly stood up. So again, huge vaccine advancements since 2014, as well as therapeutics. So very similar kind of to what we learned about in COVID. So the monoclonal antibody treatments, a big game changer. And I think we saw this during COVID too, was rapid diagnostics. I'll show you more about the kind of Ebola treatment units that I worked in. But when patients are sitting in cohabitated spaces for honestly days at a time while we're waiting on testing, they're spread within the unit. And so being able to rapidly diagnose, isolate is a huge game changer. So let's see and then a couple of the things that we continue to focus on now is, of course, early recognition, immediate isolation, rapid notification, and protecting our team members. And those are the things that don't change as we move into this outbreak. All right. So as we know, the world is smaller than it's ever been. People are moving around. There's more travel, more trade, more migration, and more risk. So we know that infectious diseases travel really quickly, and international travel makes our geography less. So rural hospitals specifically are really no longer isolated from global health events. So our preparedness really has to start locally as we think globally. So often, not always, but we do see that rural hospitals are often our first point of care. I live in the mountains of Colorado. It's a tourist town. And so we literally have people from all over the world visiting during our two big seasons, which are winter for skiing and then summer for all the recreation. And so it's a mixing pot, and we love that about it, but it also puts us at risk. And so when you think about a small rural hospital, for example, where I live, we have a 7-bed ER at a couple places. Our staffing is always limited. Our specialty resources are certainly limited. Transfers to a higher level of care or specialty care take a lot of time. And so we really have to focus on being prepared and being ready for situations that might be rare but could happen. I wanted to talk a little bit about how the CDC travel screenings help protect us all the way down to the county and regional level. I, for one, so I had to fly into very specific airports when I was coming home, and I 100% of the time always missed my connection because I was always stuck at a CDC checkpoint. But essentially, they've limited the amount of airports that flyers from impacted regions can fly into. And then there's a checkpoint at those regions. And then they go through an enhanced screening process. So it's a lot of travel history, a lot of what were you doing over there, as well as like symptom and exposure assessment. And then they categorized you into essentially two categories: no symptoms, low risk, and you get to continue your travel and you move on and you're handed off to your state and local health departments for monitoring during that 21-day period. Or if you do have symptoms or it's a high enough risk exposure history, they will help right then and there with immediate medical evacuation, isolation, and so on. I had a number of friends who did not have Ebola, but at some point from the time they departed Sierra Leone to arriving in the States, either had food poisoning or a little bug, so had a fever when they arrived, and they got to spend some time in one of our bigger level 1 isolation units throughout the States. So, but they always said they were in really, really good hands. And then, states do it differently. For me, I was the owner of 4 or 5 burner phones because they always gave me a free flip phone so that they could be sure they could contact me and check in with me. And depending on my risk level and the level of the outbreak, I either just checked in via phone or sometimes I had lovely members of the local public health department coming to my doorstep and watching me take my temperature twice a day to make sure things were good during that 21-day period. So this was all stood up during the 2014 outbreak, and it is a really good way to increase our monitoring so that we know what's going on. Just again, a call out to your local public health. If you especially are a rural hospital, but really any hospital, are you working with your public health team? Do you guys have shared protocols so that if somebody who is being actively monitored needs medical care, that you are aligned, that you have a process? Our public health team up here in Grand County, they are actively monitoring people. We don't need to know that information, but we do have a process in place that if one of those folks needs to seek medical care, that they call us first, and so that we can have a little bit of time to get things in place before somebody just showing up on our doorstep. So that would be one of my big things that I would encourage you to get in place now, is make sure you're talking to your public health team, make sure that you know what's going on, and what you would do if somebody who's under active monitoring needs to access your system, especially for emergency care. I think primary care and things like that are a little bit different. When I was traveling back and forth to the States, obviously I needed to go in for routine primary care and things like that. And I would typically just call the office and explain I was being monitored and see what their comfortability level was and say, I just need a well visit, but I'm not feeling sick. And usually it was pretty easy to take care of. So, all right, let's talk about my stories here. So I had the opportunity to go with Partners in Health, which historically is not an emergency response organization. However, they decided that they needed to respond in West Africa, and I had an incredible experience with them. If there's any public health gurus out there, this is the organization that Paul Farmer founded, and I really loved their mission, and that was not only responding to the emergency, but also creating sustainable systems, both by partnering with local government, local healthcare workers, training, education, and staying long after the outbreak so that we could continue to build systems. I arrived in Sierra Leone in November of 2014 and ended up in Port Loko, which at that point was essentially the epicenter of the outbreak in Sierra Leone. It had just recently kind of exploded. And at that time, the government and Partners in Health, which was a dual run treatment unit, was the only one in the area. It was an old school, and it was divided into a suspect and a confirmed unit. And then within that unit, patients were divided by symptoms, so wet versus dry symptoms. And I can go into that a little bit more. But when I arrived, we had no I mean, it was myself from my team, it was about 8 people. And then we were working with the local healthcare workers who were absolutely incredible. And together we really built this unit from the ground up. So we developed the triage, we developed the patient tracking. We were working with the local government in terms of testing and getting test results back, which early on was taking honestly up to 3 weeks. And so we would have people in our suspect ward who likely had Ebola, who were never confirmed, but then their symptoms resolved, they were convalescent, and actually got discharged before we ever got a test result back. And so I remember the first day that we had a patient that we admitted, tested positive, moved over to the confirmed ward, and then discharged within about 21 days. And it was the first time we really saw somebody move from admission to discharge and then to kind of our survivor care program. As you can imagine, the care doesn't stop when they're discharged. They just experienced a very, very extreme critical illness with a very low survival rate. And they're very weak when they're discharged and they need continued care. And so at that point, they would often be discharged to the local government hospital where the care teams there would take over care. If you can see in that first picture, this is a little girl who I still keep in contact with today. She's very near and dear to my heart. Her name is Mariatu, and she was one of our kiddos who survived Ebola. And that first picture is just a couple of days after discharge from the Ebola treatment unit. And then you can see a couple months later in that third picture after, working with the local government hospital, working with nutrition support and all those things, how much better she was doing in that picture. She's there with her dad. But the mortality rate was really, really high. It was really challenging circumstances. Within the unit, we did not have a lot of resources. So there wasn't running water. We didn't have a lot of medications. We were really, honestly, just focused on fever control and pain control to the best of our abilities, and then keeping patients safe from each other, which is where that wet versus dry symptom separation would come in. And so if they just came in and had like a fever, but they weren't vomiting, no bleeding, things like that, they were kind of on one side of the ward. But if they had progressed to wet symptoms, they were on another side of the ward. And the way you would enter the unit, you would start on the suspect side and you'd go from least sick to most sick, and then you'd move over to the confirmed side. And again, you'd go from, how do we do that there? I think we went from most sick to least sick there as we got closer to doffing. It was West Africa, so it was very hot, very humid, no AC, you're in full PPE. And so really you're maxing out at about an hour before you have to get through. And so it was a lot of teamwork, amazing local healthcare workers who to this day are heroes to me. And so it was quite the experience. That unit held close to 120 patients between the confirmed and suspected patients. And so it was just all boots on the ground, early days of the outbreak. And then over time, testing improved, how quickly we could get results improved, equipment improved, things like that. So testing delays, I talked about that. After my time in Port Loko, I was moved to the capital of Freetown with my team, and I was at a government maternity hospital. But we set up a Ebola holding unit triage type thing with the local healthcare workers in front of the hospital, where all women going into labor were screened prior to being admitted to the unit. Again, ER nurse here. Pregnancy, births, things like that were not my specialty. I've really grown to love it since then and learned so much. But what we really learned is that every fever could be Ebola, but women who are pregnant present with really overlapping symptoms that 99.9% of the time were nothing, but they overlapped enough where the fear within the healthcare workers, the fear within the OR we really needed to get a system in place. So a woman would arrive in labor, she would have an Ebola screening, she would enter the Ebola holding unit, and then a negative test would get her straight to the maternity ward, and then a positive test, she would do her delivery, postnatal, all that within the Ebola holding unit. We had amazing midwives who and doctors who were working in that unit with us, delivering babies. But as I've spoken about with the testing delays, even 6 hours when somebody is in labor is a really long time. And so there were a lot of babies delivered in the holding unit versus inside. It was really challenging when obviously there was emergent complications and things like that going on, because we could not get them to the OR without a negative test. One of the things we learned about Ebola during this outbreak is that it really liked to wall itself off in these immunoprotected areas. So that includes testes, ovaries, uterus, some neuro stuff. And so we did see a couple of situations where mom would have no symptoms, mom would be negative, but baby would be positive. And so there were obviously a lot of fear within the healthcare community. And so lots of extra precautions were taken to make sure that they were safe for the ward to be around healthcare workers, other moms, other newborns, things like that. Sierra Leone does have one of the highest infant and maternal mortality rates in the world. And so this was already a challenging situation, made even more challenging by the Ebola outbreak. But we were able to partner with a Dutch lab team who had created a mobile Ebola lab. And so this was one of the very few places where there was actually a lab on the premises of the hospital and the unit. And so eventually we were able to get tests turned around within 4 to 6 hours, which really improved our survival rates. But as you can imagine, that picture there is a pretty fair representation of what the holding units looked like. They were dark, there was no windows, they couldn't bring family inside. And so this caused a lot of delays in seeking care, a lot of increases in complications and mortality. And it just was not a great situation all the way around, but we did deliver a lot of healthy babies during that time. I do want to call out Partners in Health here, because they did stay and they have been working hard since 2014. And they recently just opened the Paul Farmer Maternal Center of Excellence in Kono. And so it's a 120 bed maternal and neonatal referral center. It's the first NICU in Sierra Leone. There's 3 operating theaters. It's staffed by local healthcare workers and physicians, and they've all been trained and they're excellent at what they do. And so I'm really proud to see that legacy continuing on, because I know that delivering babies during the Ebola outbreak was definitely one of the hardest moments for me. So I'm going fast. Do we have any questions or anything as I keep going? Okay. So recovery. So as you can imagine, as the outbreak wound down, the work was not even close to being over. A lot of care was delayed, specifically for things like tuberculosis and HIV. Those programs that were historically funded were not able to do their job during almost 2 years of that outbreak. So there was a lot of chronic diseases that were not treated throughout that time, which I think we know and are familiar with after the COVID outbreak. And so one of the opportunities that I had, kind of as the acute side of the outbreak wound down, was building a referral system from the government hospitals in the rural areas that we partnered with, and getting them to higher level of care. The story on the right, top right, his name is Monday, another kiddo I'm still in touch with today. But he presented at like a primary care clinic and had a big mass on his neck, which ended up being non-Hodgkin's lymphoma. At this point, we were still in an active outbreak, and Partners in Health has a lot of connections with the Boston Medical Institutes. And sorry, I got somebody coming in my office. And Partners in Health, being Partners in Health, decided that they were going to treat this kiddo, that they were going to get him chemo treatment on the ground in Sierra Leone. And then whatever happened after that, they were going to get him to the next step. And so I got to be that person. I was the ER nurse who had never been an oncology nurse ever in my life, but I'm working with a Boston's Children's Hospital team, and they're walking me through how to administer oral chemo and to check labs and to get all this done. I was doing like home health visits. And honestly, I thought it was crazy. Like, I was like, this is such a huge amount of resources being poured into one person, but that is like the heart of Partners in Health. And so I left before Monday finished treatment, but he was eventually finished the chemo. And then he was able to go to Rwanda, where Partners in Health has another hospital, where he was able to do radiation treatment, and then was eventually declared cancer-free and is growing up now. He's got to be in his 20s. And so it was just one of those little moments for me as a responder where you really come back to people first, and that it does matter, and one life does matter, and that, yes, we try to do the greatest good for the greatest amount of people in emergency situations, but being able to stop and pause and help this kid is truly one of the most life-changing experiences I've ever had. And there's 100 more stories about things like this. But the recovery after Ebola, it just took a long time. And I think it's a really interesting parallel to how rural health works today. And so we, as rural practitioners, are often needing to refer out to specialists and different higher levels of care. And while those infrastructures exist, what we often see is the gaps in between getting people from place to place. And that's really where Partners in Health played a role during the referral process. So we were sending them to the government hospital for a CT scan or to see a specialist or a specialized surgery. But what we learned is that we needed to support patients and their families, to pay for transport, to set up lodging, a lot of case management type things. And I think now up in rural health, I feel the same way, that often the barrier is not access to good care, but it's getting there, being able to pay for things. And so that was a space that Partners in Health was really able to fill during that kind of post-acute time. All right. And so here are some lessons learned from the Ebola response. Aggressive supportive care. Again, while there were monoclonal antibodies and vaccines and things like that, I did not have access to them, especially in those early days. And so we were mixing buckets of oral rehydration solution and like really getting back to that nitty gritty patient care, where you're sitting there and you're sitting patients up in bed and you're making sure they're taking sips of water. And yes, we did utilize IVs and IV fluids, but resources were limited. And so they went to specific people who were most critical. And then other than that, we just used a lot of Tylenol and things like that to keep fevers down. A lot of old school treatment with kiddos, where we would, get them up out of bed outside and just get them in a bath and try to get the fever down that way. And so it was, while I think on one side of the outbreak, there was like a ton of amazing medical intervention going on, and we saw patients, especially who were treated in the US, getting incredible critical care like CRRT and things like that. We were really all hands on deck. We needed an army of people, and we just needed to keep fluids in people, keep fevers down, and support them so their body could do its thing. And it wasn't perfect, but we worked really hard to take care of people in very vulnerable states. Second, which I think I've mentioned a lot here, is just lab. You can't put a stop on the outbreak if you don't know who's positive and separate those and isolate. And so by the time I was leaving in 2016, we were doing some field trials with point of care rapid testing for Ebola, but I never experienced that as a clinician. So our lab tests really, they went from taking about really 2 to 3 weeks sometimes to get back, to by the end, as things were winding down, you really could get like same day or next day results, but a pretty long time when you're thinking about wards that are shared and not individually isolated and things like that. We also learned really quickly that we needed specialized care pathways. And so children, pregnant women, things like that needed a different care pathway than just somebody who maybe showed up positive. We also used a model of an Ebola treatment unit, and then in rural areas would set up smaller units where people could go to get tested, screened, and then move to a higher level care if they needed. I think it's really hard to imagine being taken out of your home or your village and moved 2 hours away to a treatment unit with no communication. What happened? People just didn't know what happened to their families, and reuniting survivors with their families was its own team of people. That because people were pulled from hours and hours away, especially in the early days when there were not a lot of places to get treatment. We learned that we have to keep essential healthcare open and that there are ways to do that safely, even during an active Ebola outbreak. Communities still need routine medical care. There's still TB. We actually saw a measles outbreak at the same time as the Ebola outbreak because the vaccine clinics for all the children were being shut down at that time. So you got to keep both going. And we learned that, I think, during COVID as well. We have to invest in our local healthcare workers. And I think that speaks to whether it's in Sierra Leone or in rural Colorado where I live, we have to give these teams the support and the resources and the supplies that they need to build capacity and not dependence on the bigger systems, because they're going to be the first ones shut out when those systems are overwhelmed. I talked a little bit about this, but care for survivors, so important, not only from like a physical space, but also from a psychosocial space. They just went through a huge trauma. And, you know, they need not only specialized medical care to get through all the lingering side effects of Ebola, but also support for family planning, because we knew that it could live in semen for quite a bit of time post-infection and could actually survive or pass to others. And so there was a whole army of caseworkers that were taking care of survivors and making sure that they were physically and emotionally well. And then, of course, using every infectious disease outbreak as an opportunity to strengthen the healthcare system. And it doesn't even have to be an outbreak. I know that right now with the Healthcare Care Coalition, we've been doing a ton of work making sure that our rural communities are prepared for H5N1. And while we don't have an active outbreak, it's given us the opportunity to do a lot of education, to get the supplies in the right hands. And so leveraging these highly infectious disease to make sure that we're protecting our communities and our healthcare workers is such an important step. Let's see here. These are kind of my 3 big takeaways, if I could summarize it. And I hope these apply to your local hospitals too, as you're setting up and you're growing, but it doesn't need to be the latest and greatest technology. At the beginning of the outbreak, I remember being on a phone call with headquarters back in Boston, and they're like, "We've got iPads. We're shipping you iPads. They can go in the units. You can track patients. You can do all the things. They're amazing." Somebody had developed an app, and we're like, "Okay, time out. Let me tell you where we're at right now. There's no electricity in the units. What goes in can't come out." And so we are inside writing down our notes, and then we're hanging them to a clothesline before we doff. And then after we doff, we're going around to the other side and we are recopying our notes. So we're like at the very basic level. I'm not sure if we need iPads as much as resources. My second is wash your hands. And I mean this in like the most simple way. When you're doffing for a highly infectious disease, I'm sure many of you know, but you're washing your hands between every step and every removal, and sometimes just for fun because you feel like you need a little extra hand wash. And at the end of the day, in our rural communities, like, we can give them the fanciest technology and we can give them all the supplies, but where we really need to spend our time and energy is making sure they feel competent and safe to do their job. By the end of that outbreak, I could doff anywhere. I had doffed in a field, behind a government hospital. I had doffed with running water, without running water, throwing things into a fire pit that were being burned as I was doffing, you name it. But you could do it safely if you had the right amount of bleach water and support to make sure your hands were clean and things were coming off safely. And then my third is get the right stuff in the right hands. And I think my brain goes back to COVID really quickly on this one. I was an ER director during the COVID outbreak of a pretty big and busy ER, and obviously supplies were on the top of everybody's mind, both making sure that our healthcare teams had them, but also figuring out how to use them and have them available. But what they wanted to do in the ER was the same process they wanted to use, on the inpatient units, where staff had to sign out their N95 and check out all the supplies, where on inpatient, it was a little more controlled environment. They knew which patients were coming in, but in the ER, they never knew who was walking through the door. And so the barrier to them getting an N95 mask because of the steps they had to take was really a safety issue. And so when we're designing systems, we need to get the right stuff in the right hands in the right way. I remember during the COVID during Ebola, where's the Ebola money was a very common phrase. We knew that resources were being pooled globally around the world. We knew that CDC, WHO, everybody had warehouses there, and these warehouses were just full to the brim of PPE and things like mattresses for patients that people needed, but they were locked up in the warehouse really out of fear of running out of them, when we just got to get the right stuff in the right hands so people can take the first step. And protecting our healthcare workers is so important. And so we spent a lot of time, especially at our rural clinics, reassuring, hey, use it, put this on, use it. We will make sure you have what you need. And your job is to take care of patients, not worry about supplies, and we're going to worry about the supplies for you. So I think that was my last slide. I would love to answer any questions or share more. Let's see. I think I can see the chat. Okay, cool. We did have sufficient. So the question was, did you have sufficient PPE when you were there? Did you ever have to improvise with PPE? I would say a little bit. We didn't have like the same type of suit every single time. So there's variations between like the supplies and the brands and if it taped or zipped or not. But I never felt unsafe, nor would I have ever gone into a situation without sufficient PPE. I will say that we didn't have N95 masks for maybe at least the first 4 months that I was there. I treated patients in a surgical mask with a face shield. I know there was a lot of back and forth as to whether it was airborne or not, or whether it could be aerosolized while cleaning. And obviously, in hindsight, and now I would choose an N95 or a PAPR if I had access to it, but we were able to do things safely.
Danny, I have a question. While others are maybe thinking of questions, I actually have two. So you talked a lot about just sort of the conditions that you faced, and in a response like this, I can imagine that a lot of focus is on the immediate threat of Ebola in this case, right? And so we're worried about our PPE, our hygiene, but you also mentioned that just some of the environmental factors, the heat, the humidity, you were in high level PPE, not to mention, the sort of mental emotional impact that you were dealing with in this response. So I'm curious if you could speak to a little bit how you and some of your colleagues maintained your own well-being, both physical and emotional, while you were responding to this outbreak.
Sure. Not well, probably, as with most healthcare workers, especially when you're in it. But we did have quite a bit of support eventually from Partners in Health. So we did have a couple of kind of like an EIB, but on the ground with us if we needed to talk to somebody. But I think everybody really took to their to a different approach. Like I have a lot of friends who are writers and have beautiful blogs from that experience. I was more of like a physical exercise person. And so when I kind of figured out how I could get that done, that was really important for me. And I think one thing that we could take away from Partners in Health and how they handled things, they required us to go on a week-long break every 8 weeks. So we were working 6 to 7 days a week, but every 8 weeks we did need to go somewhere, and not you didn't have to leave. A lot of us did, but you had to take a break. And not only did they mandate that, they also gave you a stipend and continued to pay you. And so most of us learned really quickly that it was really hard to get back to the US, and then you were like quarantined with public health at your doorstep. But Europe was a lot more loosey-goosey on their restrictions, so a lot of us got to do some pretty cool travel for our breaks. But honestly, it took a long time. Like it took a long time to process everything, and I still sometimes think I haven't processed it. It was both an incredible and traumatic experience all wrapped into one. And I find myself thinking about those people regularly still.
Yeah. Thanks for sharing.
Yeah.
I do have another question, but I see there's one in the chat, so I'll let others take a turn.
Okay. Let's see. With all of our cuts from our government and Doctors Without Borders, would you do things different? I mean, obviously, yes. But what I would do different, I'm not really sure. I certainly wouldn't be cutting preparedness dollars and things like that, because I think when you're scrambling, it's the most dangerous. But I think that you can only control what you can control. And if you have the time and energy and resources to help your community, your hospital, your clinic get things in order, like I said, you don't need fancy equipment. Doing a donning and doffing training quarterly is such a huge advantage. Where we don't have to necessarily send our folks out for specialized training or have an infectious disease doc on site. I think there's a lot of things we can do behind the scenes that don't require government funding or Doctors Without Borders and things like that.
So I had another question, Danny, which is maybe related to that. Um, because when we're thinking about preparedness for something like Ebola, it seems like it is a low frequency impact here in the United States. And so when we think about, domestic healthcare preparedness among all of the other priorities that our healthcare facilities have, and sort of the competing nature of those priorities. Could you speak a little bit to
In a
why
little
you
while.
think?
Yeah. I mean,
Oh, sorry, I think we have
okay. Yeah.
someone off.
Oh,
We have someone off mute, Patricia. Thanks. So could you speak a little bit to like eh, why you think that preparedness for special pathogens or Ebola, viral hemorrhagic fevers is an important priority for um, partners here in the United States, and maybe especially thinking about facilities or partners who have funding restrictions or, operating in a rural environment where there's just a lot of other things going on like how do you balance this compared to other things?
Such a good question and so hard. I think whether you're rural or you're urban at a facility with tons of resources, healthcare workers by nature wear lots and lots of different hats, and you are often in more of a response type space where you're putting out fires. What's right in front of you becomes the priority. And so preparedness often takes the back seat. And it's so hard to prioritize. But on the flip side of things, when something comes through the door, the first question, at least me as an ER director, that I would get from my staff was, "We haven't done donning and doffing training." I'm like, "We had 6 trainings, nobody showed up." And so I don't know the magic key to getting people at trainings engaged and things like that. But what I can say is keep offering them, keep sending out that education. It doesn't always have to be super formal. It can be as something as I know a couple of the ERs up where I live do halos, so high acuity, low occurrence events like you were talking about. And so actually this month they are focusing on Ebola and what that looks like, and a little reminder what our pathways are. But I will die on this hill. Preparedness is so, so important. Infectious diseases are changing on a daily basis. And while Ebola is like a big, scary one, and it's also very far away, things creep up like we saw with COVID. And so we never know what's around the corner. And so having a basic level of like competency, preparedness, and supplies is exponentially important.
Absolutely. Thanks for that.
You can stay on a few more minutes. I'm going to go ahead and put our post-session surveys in the chat. So this is our first survey just with your general experience, and then this next one I'll send will be the CE survey as well. And we hope that some of you can join us for our next scheduled session on Thursday, August 13th. We'll have another session from noon to 1 discussing clinical and community approaches to gun violence. So we hope you can join us.
Great.
Oh, it looks like we have another